Test, test, 1, 2, 3, 1, 2, 3, test, test. Hey, Andrea.
Hi, Quinn. Thank you so much for getting everything so set up. I know it was crazy.
Oh, yeah, no problem. Just an FYI, I will probably just remain without video and stay muted during the meeting. Just
Okay.
in case, if anybody needs me, just they can just yell for me. But I mean, I don't really see a reason why I need to be, on.
Okay. Is there there's not a obvious password required or anything, it's just open?
That's correct. Yes.
Okay, great. Hope it all goes well here.
And I've got the other Zoom pulled up as well, so I'll redirect everybody to their email.
Oh, thank you. I was gonna say put it in the chat of the other one.
Yeah, that's true. I could just put the meeting ID in there, and then they can just get on themselves. That's a good idea.
I've been the Healing Grant community meeting that we do by Zoom. We've done, I don't even know how many at this point, maybe a dozen. And I'm learning more and more and more about how to use Zoom now.
Oh yeah.
Yeah, and there's always I even did I did a week-long program review at the University of Kentucky, all by Zoom.
Oh wow.
Yeah, it was really, I mean, I applaud you all that manage it because it doesn't look easy.
Oh yeah. It's I've learned a lot too over the course of the past couple months, but yeah, with the Economic Recovery Committee stuff, it was kind of a full submergence. So
right. Trial by fire, is that what they call it?
Right.
Right.
But Andrew, just a heads up, we are live on YouTube. I think I put it in our group text, but
Okay, thank you. People are watching me fix my hair.
that's right.
No,
Hello, can you hear me?
I can. Can you pronounce? Oh, let me turn my music off here. Can you pronounce your last name for me?
Yes, it's Boateng.
Boateng. Nice to meet you. I'm Andrea. I'm the staff liaison to the mayor's office.
Excellent. Nice to meet you, Andrea.
Nice to meet you too.
Thanks for the invite. I appreciate it.
Absolutely.
Hey, Andrew, as folks come on, can you just let them know that we are live on YouTube currently, just so they're aware? Thank you.
Sure. Guess you heard that. Is it Dr. Boateng?
You can call me Adu or Dr. Boateng, either one.
Okay. We are live on YouTube at the moment, so in case you want to floss your teeth or something like that, know that YouTube will be watching.
Duly noted.
Okay. Mr. Halligan?
I'm here.
Hi, how are you?
I'm great. How are you this afternoon?
I'm doing well. Been told to let you know that we are on live on YouTube. So just so
Okay.
you know that we are live right now.
Terrific. Thank you for letting me know. I appreciate it.
Thank you. There's two of you on right now. Oh, and more coming on. Oh, there's Timothy Johnson.
Hey,
Good afternoon. How are you?
great. Good afternoon.
Good. We'll get started shortly as people log in, and we are live on YouTube right now.
Okay, great. Hey, Mike.
Hey, Timothy, how you doing?
Good. How are you doing?
Terrific. Now I gotta get me one of those fancy banners that says "That's country people like you."
All this is it's a pic file, a graphic. Nothing fancy at all.
It's awesome.
Oh, we're hot and popping now. Hi, good afternoon. Welcome.
Hi, how are you?
Good.
Let me see.
Councilmember Plowman, good afternoon. Brandy, hi, how are you?
Good.
Good. What's your appropriate title, Brandy?
For you or just in general?
Oh,
You can call me
for-
Brandy, but
Brandy,
Dr. Brandy
okay.
White.
Okay, thank you, Brandy.
Hi, Vivian.
Hey, Brandy, how are you?
All right. How are you doing?
Doing pretty good.
How's everybody else doing?
Good. Thanks. Nice to meet you.
It's hot outside.
I'm cool. I'm inside, but it's hot. I've been out.
Yes, yes.
Hey, Andrew, can you hear me?
I can.
Okay, great. Thank you.
It looked like you were trying to dial in twice.
I know I did. I'm not. used to
Okay,
doing
that's
this
all
on my
right.
phone.
Will Eve be joining us too, Kathy?
I'm sorry.
Will
I
Eve
think-
be joining us?
I don't think she's going to join on Zoom. I just talked to her. I thought she said she was just going to watch it. I don't know.
Okay, that sounds great. Thank you.
Uh-huh.
Oh, there's one of our chairs.
Whoa.
Dr. Talbert, hi.
So how you doing?
Andrea, I see Miss Talbert just connected.
There she is.
Good. And then Gerald Smith, it should be on his way as well.
Great. And I see Dr. Akins as well. Good afternoon.
Yes, I was on the other one. My apologies.
Oh, no, our apologies. Sorry for that.
And Andrew, as far as the statement, is that something one of us needs to read, like myself or Lavoria?
Yes, the statement. Do you have it?
I do.
Let's wait on Lavoria
Sure.
and,
Yeah, I wasn't gonna. I was just curious
Yes.
who was doing that.
oh, yes, one of whoever's leading the meeting.
Okay.
You are going to tag team it?
Yes.
Okay.
We'll
Yeah.
knock it out. And I think, let me see what Ms. Roz.
Hello.
Good afternoon.
Hello, everyone.
Hi.
Hey, how are you?
And I see Dr. Smith is on as well.
Yes,
Okay.
hello, everyone.
Hello.
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 How many
Take
do
all
you
smiles.
how many do you have on the Zoom call?
Look, I see 13.
It's good.
And one is, of course, me, and one is Quinn, who is managing the whole Zoom for us.
Okay,
So 11 of the committee.
wonderful.
Well, 10 of the
Fantastic.
committee.
Oh.
Yes.
And real quick, I'm sorry to interrupt. Councilmember Plowman, could you
Yes.
turn on your video?
Well, I'm doing this on my phone.
It's
Hey, Quinn.
okay. It's okay.
Okay.
That should be fine. Thank you.
Okay. Thank you.
I think we can go ahead and get started.
Okay. On behalf of Dr. Smith and I, we just wanted to kind of open up and say a few things to you guys. And first of all, thank you so very much for being willing to do this on behalf of the mayor. We quickly tell folks this was not something we decided to do quickly. We prayed about it and thought about it and we talked about it. And so we're here and we just thank you all so very much. And so Dr. Smith's going to do the what our purpose is, kind of give you some guiding principles and some things. And then we're going to let you all go for it. So Gerald, go ahead.
Okay.
Dr. Smith, before you start, can we have the reading of the statement, the virtual meeting statement, which will have to have Dr. Talbert, I think, is going to read that for us.
So, and welcome everyone. And I'm Takia Talbert. So I do want to make this statement in the state that we're in, but due to the COVID-19 pandemic, state of emergency and Governor Beshear's executive orders regarding social distance, this meeting is being held via teleconference pursuant to Senate Bill 150 as assigned by the governor on March 30th, 2020, and Attorney General Opinion 20-05, and in accordance with KRS 1.826, because it is not feasible to offer a primary physical location for the meeting. So that's just important to say. Thank you.
Okay, thank you.
All right. Good afternoon, everyone. And again, I want to echo Ms. Aiken's appreciation for your willingness to serve on such short notice in a very constricted time frame. So I won't be long. Hopefully you will get a copy of this document that Ms. Aikens and I put together and the mayor has read and approved and endorsed as well. And I'm not sure, Ms. James, do they have a copy of that document in terms of the name and the purpose and the guidelines and all of that, guiding principles?
I was off last week. Dr. Talbert, did you all receive anything last week?
Oh, yes, we do have it. I think that Dr. Smith was referring to the committee members.
Yes, do they have that?
And the mission, just kind of like the 4 or the 5 different subcommittees and things of that nature. Now, it was my understanding that Chris Ford was going to send that out, or Teresa Maynard.
Okay.
So if you haven't gotten that, that's okay. We'll put this list down and
Make sure you have it.
we can ensure that people receive that original.
Yeah, we want to make sure you have that. And I just kind of want to make sure that you understand, of course, the name is the Mayor's Commission for Racial Justice and Equality. And so that you'll know what the purpose is. And again, you will receive. Purpose is to assemble a diverse community members to listen. We'll dismantle systemic racism in Fayette County. All right, I'll say that again. Again, you're going to get the document, but the purpose, diverse community members to listen, discuss, and create empowering solutions that dismantle systemic racism in Fayette County. So that's the purpose. And then there are guiding principles that you'll receive as well, which sort of gives you a little an early framework in terms of what your subcommittee will be doing, that focusing around acknowledgement, ask, address, and action. We say acknowledgement. Of course, it's already been acknowledged that systemic racism is in Fayette County. Ask, this is where you get into the discussions, asking questions, sense of your personal observation and experiences. Address, thinking about how to address some of the issues that have been discussed that you are. Then, of course, finally, the action. That's the outcome, essentially. That's the goal. And so there are 5 subcommittees, and I won't go through all of those for the sake of time. You're on health disparities. What we did decide to do, Ms. Akins and I, we did decide to rather let the goals and objectives evolve out of each subcommittee as you work on your recommendations. And what we also did to kind of give you a little bit more guidance so you won't just be out there floundering somewhat, and hopefully this is helpful. We did recommend that each subcommittee be guided by what we call overarching goals, which is a little nuanced because when you listen to the overarching goals, they actually sound somewhat like objectives. Of course, keeping in mind that the goal is the outcome and the objective is the action that is taken in order to achieve the goal. But here they are, the 3 of them. First of all, to identify both systemic and systematic practices of racism. Identify both systemic and systematic practices of racism, which has fostered structural inequalities, challenges, and deficiencies in Lexington Fayette County. That's one overarching goal, which again is somewhat like an objective. Secondly, to assess the historic marginalization of African Americans in this community, to assess the historic marginalization of African Americans in this community. And the last one, and again, these are overarching goals for each subcommittee as you determine your individual goals and objectives for that subcommittee. The last one is to simply recommend and advocate the systemic changes that will protect and promote racial opportunity, diversity, equity, and unity in this community. All right. So again, you're going to get all of that. I kind of move through it quickly because time is critical, and want you to sort of begin with your agenda. And I do want to thank Dr. Talbert very much, and thank you, Dr. Williams, so much as well, volunteering and taking on this task. We are definitely leaning and depending on you, and we just thank God for your service and the wisdom and knowledge that each of you bring to the table for this very critical discussion. So thank you very much. So I'm going to step aside now, unless Ms. Akins, you have something else to say. We're gonna zoom out.
That's right. I just want to follow up as you head into your session and each of the meetings that you have. Don't be afraid to deal with the truth. This is not a time to do any sidestepping or surface skimming. You've got to deal with the truth. And it's going to be, and I hope the driving force will be the love you have for this city. And we all want to make Lexington a better place for the next generation. And you've got to believe that every human being deserves dignity, freedom, and equality here in this city. And the last thing I'm going to finish up with is commitment. This is going to be hard work. It may even be painful work. So I pray that none of you throw in the towel before we get finished. And we're here to just, if you have questions or anything that we can do, and we look forward to working with you. And we thank our co-chairs of the subcommittee and each of you who've been willing to serve. Now y'all go to it and we zooming out.
All right. Bye-bye. Thank you all.
Thank you.
Okay, thank you. Bye-bye.
Bye-bye.
So we will get started.
Yes.
So I am Takia Talbert, and they had mentioned that I'm one of the vice chairs, and I'm very thrilled and honored to be amongst just this fabulous panel of wonderful people, because I believe that the sky is the limit when you get such great minds together and we have the opportunity to talk and get this thing out there. And as Roz mentioned, is not be fearful of facing the real truth, right? to come out with a real product on the other end. So all of you did receive the agenda for today, correct? No? Wow. Okay. That was, we were thinking that was sent out. So let me, Andrea, I'm gonna send you, because maybe you have everybody, I want to send you the agenda because we had that, and it was my understanding it was being sent out to all the members. So our apologies. I should have followed up with that. I will send that. But let me just tell you what's on it, and then we will send that to you. But the agenda for today is we wanted to start with introductions, a proposed meeting date so that we can all agree when we're going to be able to get together. Dr. Williams and I decided that maybe we needed to use consecutive weeks so that we would maintain our momentum and our energy around meeting and keeping ideas flowing. So if that works for you all, we will be very thrilled. I know the doodle poll, now I did see that. So many of you had signed into that. So I think that we have good energy around that in the meeting times. And really, as far as the subcommittee purpose, and I'll have to get the documents that Dr. Smith was using so that we can make sure you all have those fundamental or foundational documents for the subcommittee purpose, et cetera, because that would be us, right? So I think that we would have some discussion around that we could talk about that. And then Dr. Williams and I thought we could talk today a little bit about the barriers and why we are where we are with the status quo, and then kind of end this session for talking then about next steps, okay, for the next meeting time. So does that sound reasonable to everyone? And so while I try to kind of gather some of these documents and have them sent out to you, again, I'm Takia Talbert. I'm a registered nurse by training. I work at UK Healthcare and also am the executive director for diversity and equity and inclusion here. So this is a great segue for me. So we'd like to hear from all of you. Just a sentence, who you are and who you're affiliated with, and why you're a part of this and what you can bring to the table, which I think is a lot more than what you would say today. And I'll also ask that everyone please mute your phone. Thank you. Mute your phones if you're not speaking so that we can all hear our colleagues well. And we can go in order. Dr. Williams, why don't you lead us, and then we can look, I will look on the screen. And if you all don't mind, I'll kind of just go in order that you're listed on my screen, if that is agreeable to everyone.
Sounds good.
Okay, great.
Thank you, Dr. Talbot. Hello, everyone. Thanks again for joining this committee. We're so happy to serve with you and very excited to see who we have on our committee. I'm Lavora Williams. I'm an associate professor in the College of Nursing at the University of Kentucky. My research focuses on health inequities among African Americans and medically underserved individuals. And primarily my work is conducted in African American churches. So very excited again to serve in this capacity with you all.
And so the next person up would be Mr. And forgive me if there are titles I should be using, team. I just don't, I'm learning everyone, but Quinn Welch. I think that's, yeah, Q.
Hi, yes. Good afternoon. My name is Quinn Welch. I work in the mayor's office, and I'll be assisting just with setting up the Zooms and sending out the meeting notices to the public, in addition to streaming us on YouTube. So thank you very much.
Thank you, Quinn. And next we have Adu Otang. Sorry, I may have messed that up.
No, it's fine. It looks a lot more intimidating than what it actually is. It's Dr. Adu Boateng. So okay. Just like boating down a river, that's all we got.
I love it. I'll remember that analogy.
I've had to say it a few times. So yeah, thank you for this invitation. I wear a few hats professionally speaking. I work for the Department of Justice during the day, but I'm also a private practitioner. So I have a small private practice that I opened about 2 years ago. And that has really been an enjoyable thing for me. I'm excited to kind of share my area of expertise. The subject at hand obviously is very overwhelming, but as Dr. Williams just alluded to, in terms of barriers, there are some barriers that are unique to African-American populations as it pertains to mental health. So I'm very interested in exploring that, talking more about that with you guys.
Thank you. And so next we have Andrea James.
Good afternoon. I'm delighted to be on a Zoom with all of you. I am here today representing the mayor's office, so I'll be the staff liaison. There's several of us assigned to each one of the subcommittees, and my role is to take notes and to get you all whatever you need in order for you to fulfill your task. So I'm here for any research or data that I can retrieve for you, and whatever I can do to make sure that this is smooth sailing as much as it can be. Thank you all.
Thank you, Andrea. So we'll really be depending on that young lady, very capable. So thank you so much for that. The next individual is Brandy White.
Hello, everyone. I am Dr. Brandy White. I'm an assistant professor at the University of Kentucky, the College of Health Sciences. My research focuses exclusively on African Americans. And right now I'm focusing on how to promote cardiovascular health for Black women living in public housing. So I am excited and delighted to be here. Two women that I admire a great deal. So this is going to be, I know we have a big task in front of us, but I'm confident that we can come up with some strategies.
Thank you, Dr. White. All right, so next we have Ms. Casey Allen Bryant.
Good afternoon, everyone. I'm Casey Allen Bryant, as Dr. Talbert said, and I'm here representing several agencies, I do believe. Primarily, I'm here representing the Lexington-Fayette County Board of Health, which I've been on the board now for almost 12 years. I was chair up until June 30th. I am still, of course, an ongoing member. And I also am a lecturer at the University of Kentucky College of Nursing. And I've been a public health nurse in this community for over 20 years and have worked with a vast variety of vulnerable populations.
Thank you so much. Thank you. Glad to have you. Next we have, and I believe this, Vivian, Miss Leslie Bibbs, I believe that's you. The LBW.
All righty. Yeah. Good afternoon, everyone. I'm Vivian Leslie Bibbs. I'm the director of the Office of Health Equity for the State Department for Public Health. I've been in public health a long time. I've also been in clinical practice, and I've also done the research side. So I think I have a pretty good perspective of all three of those focus areas. So I'm excited about addressing some of those disparities and inequities that we're seeing in our populations, and especially in Lexington Fayette.
Great, thank you. So next, Mr. Mike Halligan.
Mike Halligan. Thanks so much for the invitation to participate in today. I'm CEO of Disparities Food Bank. I've been at the food bank for about 3.5 years. I've been involved in hunger relief work.
Mike, we're having difficulty hearing you.
Yes.
Right, hold on a second. Okay, is this any better?
Better.
Great. Sorry about that. Note to self, the Bluetooth headphones don't work. Got it. Mike Halligan, CEO for God's Country Food Bank. I've been in Lexington at the food bank for 3.5 years. I've been involved in hunger relief work for the better part of 20, including serving on a couple of boards, working for the National Hunger Relief Organization, Feeding America, and also doing some work in supporting hunger relief through a couple of the corporations that I've worked for over the years. I was originally born and raised in Muscatine County, Iowa, and I can share some interesting stories with y'all when we get into our work about working with farm workers who travel from community to community, helping with planting of crops and harvesting of crops, many of whom are undocumented. So those are some of the things that I bring to the table. I can also share with you some really interesting statistics that we've seen the last 13 weeks that really demonstrate how some of the injustices that we see that are very systemic adversely affect marginalized communities when it comes to a crisis like COVID-19 and cause those individuals to be at greater risk of hunger.
Thank you, Mike. Appreciate
Yeah.
that. Okay, so next up we have Rabbi Lifton.
Rabbi.
Rabbi.
Rabbi Litvin, I'm the director of Chabad Lubavitch in Eastern Kentucky, which is the largest Jewish organization in the world. I'm also the personal emissary of the Lubavitch Rebbe, Rabbi Menachem Mendel Schneerson, who's the foremost leader of American Judaism. I do a lot of work with various groups in the community, and I'm very blessed to be serving here.
Excellent. Glad to have you, and thank you for the correction. I wasn't sure if that was a name or a title. So thank you very much. Next, Mr. Overstreet.
Hello, my name is Stephen Overstreet. I am a community member, first of all, and I have done many events to advance efforts to improving our communities. Most notably is Douglas Park. As far as my help on this commission, I'm actually not really sure how I could help on this subcommittee because my work has never been in the area of healthcare or health discrepancies. So I'm struggling to understand where I can fit in and where my role can be valuable.
I can help you with that, Mr. Overstreet.
Okay.
The most important thing that you have said thus far is you are a community member, and just that is exactly what we need on this committee. Your lived experience of being a person of color in Fayette County is going to bring a great deal to this committee. So we're happy and excited to have you.
I appreciate that. And I can definitely understand where me being a community member can absolutely help, because we need community members' voices in every aspect of this situation. Like I said, my struggle is just not knowing how to speak for my community in necessarily this area, because this is not my area of focus. It's kind of like asking a gynecologist to look at my heart problem. I don't know how any other way to put it.
But as a consumer, you can probably think of what an ideal state would be like for healthcare, right? You have some things that you would want to advocate for other people that are Black and brown, right? Maybe.
Absolutely, absolutely.
Okay. So don't sell yourself short. So I think you have much more to bring to the table than you're giving yourself credit for.
Well, I don't want you to think I'm selling myself short, because I believe I'm capable of anything and everything. But what I just want to make sure that my talents are being used to the best of their abilities, and that this commission is actually going for something that is going to be tangible and actual changing, and something that we are actually going to see. I work in areas where we are successful, and I would like to continue to be successful and not just be as something to see. You know.
Well said, sir.
Yes.
I'll end it on that one.
All right, thank you.
Thank you. Next up, I believe we've not heard from Timothy Johnson.
Timothy Johnson. I'm the president and CEO of United Way of the Bluegrass, a 99-year-old philanthropic organization charged with delivering impact in Fayette County and throughout the region. We work very closely with the nonprofit community here and about the Bluegrass area, and very thrilled to be part of this commission. Our state is to fight for the education, income, health, and basic needs of every person in the community. And as a person of color with lived experiences throughout the Institute of the U.S., I'd like us to make sure that we are able to capitalize on that and really do fight for every person in the community. I know that there's some work that we can do to improve that. Also on the side, I'm also an emergency medical technician, and I've been an EMT off and on for the last 20 years.
Thank you so very much. And maybe Kathy Plummer?
Yes. Can you hear me?
Yes.
Oh, good, good. I'm Kathy Ploman, and I represent the 12th district on our council, which makes up 70% of the land mass of Fayette County. So it's a big area, a lot of rural. And I think I just followed Timothy. Like Timothy, I was president of the United Way from 2000 to 2009. And that's 83, or was 83 health and human services organizations. So I pretty much know what's out there in terms of health and human services. But I do bring the perspective from council and interact, obviously, with all 15 council members, including myself. And I think that'll be a different perspective that's at the table. So I look forward to serving and for sharing that perspective with you. Thank you.
Thank you. Glad to have you all. So this is fabulous. And I believe that Andrea was able to send out the agenda to everyone. So have you now received that? And we apologize. We'll have this, we'll make sure you have all this for sure before the next meeting. So is that a yes, maybe? Nod your heads if you, okay. I just want to know, great. Yeah, thumbs up works. Okay, so we've made it through the introductions then. And I guess really for a matter of logistics, the proposed meeting dates for the most part. And Andrea, did you by any chance look at the response to the doodle poll?
I did. We heard from everyone, but Dr. Gilliam, Brandy, yourself, and Councilmember Ploman. And the dates that were agreed upon between all of those were what was proposed. The dates and times were agreed upon.
That's good.
Fantastic.
Yep.
So I thought I did that Sunday, but we proposed the date, so we were definitely good with them.
That's perfect. And I've been told that if the committee's good with it, we'll go on and publish those dates and they'll be on the website for everybody to reference.
Okay, that's beautiful. So, and it looks like I'm getting thumbs up from you all. Great. That's what we can proceed with, Andrea, because it sounds like the team is good.
Yes.
So,
And one more question, Andrea. Do you guys also send out calendar invitations to the committee?
Right.
For
We
those
can do that
dates?
if you would like.
That would be awesome.
Yes, I like those too.
yeah. With all the stuff embedded, of course, in the link, right? So if we could-
Absolutely.
yeah.
Thank
that'll be
you.
Real quick, can we go ahead and just say those dates and then just somebody make a motion and
Okay.
have everybody vote on it?
Thanks, Quinn. Do you know the dates, Dr. Talbert?
I'd have to go back.
I'll put it here in the
Let's see.
7:15, 7.
Do you have them in front of you? Probably take me more time. I can find it in the email.
Let's see. Is it
Oh.
is the next one 7:15 at 4 p.m.?
4 to 5.
Yes.
Mhm. I have all the dates if you want me to list them, Dr.
Yes.
Talbert.
Oh,
Yeah.
thank you,
would be
Casey.
fabulous.
Yes, of course, today, July 15th at 4, like he said, July 22nd, 3 to 4, and July 29th, 3 to 4.
Yes.
Motion
are
to
all
approve those
Wednesdays.
dates for future meetings.
Second.
Okay. So first by Rabbi Lipton and second Mike Halligan. And so all those in approval of that denote by aye or shake of the hand.
Aye.
Great. Great.
Aye.
All right. See everybody's notions there. Okay, fabulous. So therefore, motion made and properly carried and approved. So there we go for the minutes. Thank you. So I'm going to turn to Dr. Williams, and do you want to talk a little bit, Laboria, on kind of our overview and kind of start going into, and for the subcommittee purpose, I think that we have some levity there and some space because it's about us, right? So we can talk more to that and develop that and be more specific. So
Yes. Just broadly speaking, because you guys come from so many perspectives, and what's really exciting about this committee is that you all are boots on the ground. You've been doing this work. And so what we thought we would start today is conversing about what are the barriers that comes to mind very easily to you all from what you're hearing from the populations that you work with. And you guys can just jump right in.
This is Brandy. A mistrust of the healthcare system. And I'm speaking with UK healthcare. I hear that a lot with residents.
Yes.
So that's a big barrier.
I would say, this is Timothy, a lack of direct access. And what I mean by that is, based on the research that I've done in my time here, there's very few doctors, clinics, medical facilities that are actually embedded in Black communities and communities of color. So just having some direct liaisons, navigators, whatever you want to call them, in lieu of having doctors' offices there that can help make referrals and help get people to the resources they need in a very non-threatening fashion.
Yes.
This is Casey. I would say that along with a mistrust of the healthcare system, a fear of encountering racism from healthcare providers is a big barrier. For example, not getting the pain medication requested for fear of being seen as a drug seeker, or early in the COVID days, there was a few remarks about I couldn't get a COVID test. Now we're long past that, but that is an example that came back that we saw in March.
Building on what Dr. White and Ms. Ellen Bryant just said, the vicious cycle that's created when patients feel what they bring up is being ignored, and they're more hesitant to say something when they need something, because they feel if they do say something, it'll, number one, be ignored, and it'll just be written down as a problem patient, which causes a great deal of symptoms not to be mentioned, and just goes from there.
So with regard to mental health treatment, when we talk about underutilization of services by African-American communities, it's a well-researched topic for some of the same reasons that you all are talking about in the healthcare industry. So there are three. First and foremost, finances. Seeing a private provider is expensive. If you are someone who is underinsured, that can also be a bit of a barrier just in terms of the financial aspect of choosing between am I going to pay my rent, or am I going to go talk to a therapist that I don't know? It's simple pragmatism there. Probably the other most significant is accessibility to culturally competent providers. Individuals whom they feel are trustworthy, regardless of race. Someone who they feel that is not judging them, someone who is not diagnosing them or over-diagnosing them based on their perceived notions of what the complaint is. There's one study that talked about how African Americans are routinely diagnosed for schizophrenia after reporting things like being able to talk to God, something simple like that, or talking to their ancestors. That's looked at by some providers as psychosis. So it's really important that we not only have, access to services, but who are they seeing when these people go see the services? And finally, probably the biggest, just anecdotally in my practice, is just stigma in general. Individuals actually accepting the fact that they may have mental health issues, understanding that it's treatable, but also understanding that, going to talk to a psychiatrist or psychologist doesn't automatically mean you're crazy or it's irreversible or it's a sign of weakness. So those are kind of the top three that come out in research, but certainly I'd be interested to explore others. And I really appreciate you, Mr. Overstreet, for being candid in your approach about, I'm not really sure about this health stuff, but, a lot of times in graduate school, my frustration was we write all this research about individuals, but never really talk to the individuals. So I definitely want to reiterate your input is probably as important, if not more important, than anyone else on this panel.
Absolutely.
Well said.
And I appreciate that.
And I would also say, in some of the work that I do is in addressing some of those cultural competency issues is is what the workforce looks like, what the healthcare workforce even looks like in Fayette County. It doesn't look like us that are on this panel. So that comes up often about not only mistrusting the system or feeling comfortable, but you want to see somebody who looks like you when you have to go through that healthcare system. So, you know, that's something else to consider as well. And all the things that we talked about.
I would want to point out something too that's actually very simple, but it's a complaint I hear time and time again. It's just the timing of doctors' hours or healthcare providers' hours, whatever type of healthcare provider it could be. You know, people of color are often not, they can't just take off in the middle of the day or can afford to, or they may not have childcare if they're at home. And so if you're talking about most healthcare providers have that time window of say 8 to 5 or 8 to 6, that may not work for everyone, especially those people who are in service industries and do not have the flexibility like others may have. And so it's a very simple problem, right, to identify, but it's complex. It's a complex issue for that availability.
I'd also like to say, I thought it was interesting, the various other subcommittees, because I think that we all sort of have cross-pollination with each other, looking at some of the social determinants of health. You know, you all have touched on some of them, things like, you know, poverty, things like insufficient employment or underemployment, you know, insufficient sort of education, all plays into people's accessibility or their willingness or ability to be able to access healthcare and understand and have the wherewithal to access our healthcare system. It's not the simplest system, as we all know. And those who may not have the understanding or time or luxury of being able to stay on the phone and talk to person after person or access a clinical office often find themselves on the outside of receiving adequate and appropriate services.
Yes. Mr. Overstreet, did you have something that you wanted to add to that?
I was just going to say that I did have a conversation last night, not necessarily pertaining to the healthcare, but just pertaining to the way our communities move as a whole. And it's about who we trust and how much we trust that person. So in the healthcare industry, if we have an inherent distrust for someone who doesn't look like us, and then we have to go see that person and depend on this person's diagnosis and to tell us what is wrong with us, we necessarily may not trust that. And another thing is the proximity that I think Mr. Johnson was talking about. That's how I live in West End, and the closest healthcare facility for me is the health department. And I can't just run in the health department if something happens and expect to be seen anytime soon. And for me to get to a hospital, I have to drive at least 5 to 6 miles. I mean, I really don't know how far away St. Joe would be the closest, maybe. But it's just not a proximity thing to where if I don't have a vehicle, then it's very hard for me to get from where I am to where the hospital is. And especially if it's for something that's not life-threatening, then why do I need to take all of that time out of my day to get over there to see them when it's so far away from where I am?
Understood.
I could just connect something Mr. Overstreet said with something Dr. Boateng said earlier, especially when visiting a healthcare professional is a huge hindrance. If you found childcare and you got across town and you took a day off work, and then you face a healthcare professional who has zero cultural competency, which I cannot stress enough how much that specific issue of cultural competency needs to be addressed here. But when you face someone who it feels like doesn't know what you're saying, and when addressing mental health, which is going to be a major issue, so much of, because of cultural views, so much of that is in the wording of how you explain it to the patient. And when the only answer a patient gets is, yeah, that needs to be addressed, you should do this entire process again at a different building 2 miles from here, 2 weeks from now, it creates, again, a despair in the patient where I spent a whole day of my life arranging this and I've gotten nothing out of it. Why should I spend another day 2 weeks from now to face another doctor who doesn't understand where I'm coming from and what my issues are to tell me the same exact thing?
Yes. Ms. Taylor, you just left, Taylor. I just made a comment in the comment section. Do you want to speak on that?
Oh, okay. I wasn't sure if I was supposed to be speaking. How are you doing? Everybody?
I'm great. I don't think we heard your introduction, did we?
No.
Go ahead. You want to introduce yourself briefly?
My name is Leif Taylor. I'm a local entrepreneur artist, and I also work in, I teach code to kids at William Wells Brown.
Okay, great. Would you share the comment?
Yeah, so the comment I was saying, one of the issues with healthcare is the fact that, the structure in and of itself is detrimental. I used to work in a healthcare facility. Like I used to work at UK when I was a student. I worked there for several years in different capacities. And one of the things that I noticed and even notice now is the fact that, you have 12-hour shifts for most nurses and even doctors that work, these crazy hours. And when you have end of your shift fatigue that contributes to irritability, and then the lack of communication that happens with patients that come in. And, I believe somebody mentioned earlier about taking off work and not being able to get there during certain times. So you have end of shift irritability. Then you have a patient coming in. Most patients come in if they come in after hours, and that means they're going to the emergency room. So that coupled with a variety of different societal things adds to the stress of going to the hospital. And so when you're talking about disparities with doctors and how they deal with patients, specifically African-American patients, specifically women, then there's a huge breakdown in terms of trust, in terms of quality of care, in terms of treatment. And those things, I think, add to, the stress of being sick to begin with. And then that coupled with not being heard because, you're kind of moved along the pipeline, so to speak, and waiting for the next shift. And then you have to re-explain your issues all over again. And yeah, it's just a conundrum that needs to be addressed.
Yes. Thank you for that insight.
Another thing that I would like to add to that, and it kind of piggybacks on what he was saying, was just the communication with healthcare providers where they ask you about a family history, and maybe you say your family history is diabetes or something like that. And then they automatically start to treat you for diabetes, or automatically start to put you into those categories when that is not necessarily something that I'm dealing with or I have a struggle with, so those type of things. Because my grandmother, I believe she died of heart disease. And so heart disease has been something that all my healthcare providers have always paid attention to, but I ended up getting sick with something else. And they weren't paying attention to that, necessarily listening to what I was saying.
I'm curious, Stephen, what was the assumption? I don't want to know what you were affected by, but I'm curious, what were the assumptions that you saw when you met that healthcare provider?
So I lived like the prototypical, I'm never going to go to the doctor life. So I waited until it was really bad and that it was really like affecting me to where I had to go to the hospital. But when I got there, there were all of these tests that were run on me to see what was wrong with my heart. And there was nothing wrong with my heart. It was just that I was very stressed out. And so I did understand that it affected my blood pressure and all of this, but because of my family history, it was more concerned with heart disease rather than what was actually going on in my actual life that was affecting my health. If that clears it up for you.
Yeah, no, thank you, Stephen. I appreciate it. So a question for the medical professionals on the call. Does that sound like the same protocol or a different protocol that one would go through when somebody presents with, a health ailment that doesn't match the history? Does that sound different, or does it sound the same as a typical protocol?
What struck me
I'll let the
as
nurses answer if they want to.
what struck me as Mr. Overstreet was speaking was the history taking, where the provider had acknowledged the family history and seemed to have focused more on the family history than on the patient in front of them. So more about his history other than his family history is what struck me as he was speaking.
You know, having come through the PA program at UK and practiced in clinical medicine for a while, you're not trained to think of what comes in with the person as a whole. You treat the symptoms and that they present with at that time. So, you know, they come in with whatever they say they're there for, and then you kind of create your, you know, after your history, your top three things that they could be there for. You think that they could be treated for, and then, you know, we didn't learn that when we were coming through school. Now, I will acknowledge that the University of Louisville, and I'm going to put them out there, has done a better job of addressing cultural competency with their medical school folks than the University of Kentucky. So they're at least seeing that implicit and unconscious bias is coming through when these professionals come out. It's not just medicine, it's dental, it's the pharmacist, it's, you know, our other folks as well. So, you know, they're recognizing that needs to be a part of the medical training to have that cultural competency piece, to address those cultural and social norms, to kind of think of the whole person that comes in and not just what they walk through the door with. So I think that's something that, you know, a model that and other schools need to look at.
And, you know, I would just like to add that I think sometimes what is protocolized is what makes people comfortable when they're not culturally sensitive or competent. If I can just stick with the program, I don't have to deviate from that and look at the gentleman or the female that's in front of you, right? So I just wanted to echo that, and being in healthcare myself, I think that it's very important. And it seems like with many of you in your comments, that's a general theme, that as we think about our overall or overarching purposes or purpose, that would be one thing that comes out of this, is the whole cultural competence piece. And Louisville is probably one of few, because a lot of people in preparation of providers don't provide a very good, strong curriculum. Done a little research on that as well. So anyway, so that's outstanding that they do, and they've at least started that process.
Yes.
So just to be mindful, team, we're at about 3:48, so we have about 12 minutes left. This has been great dialogue, so we want to make sure we've included everybody, and I believe everybody has had an opportunity to share.
We didn't hear from Kathy.
Okay, yes, she's the only.
I think I'm actually traveling, and so I'm in a car, and my husband's on the phone right now. So, but I really enjoyed just listening, because, you know, I'm obviously white. My dad was a doctor. I've been kind of sheltered from that my entire life. So I thought it was really interesting to hear your all's perspectives on disparity in the healthcare. So I'm sorry. I can hear my husband in the background.
If I could speak on one more thing, something we discussed early is how the other committees also intersect with this one. The fact is that in more affluent communities, it's very common for someone to have a physician who knows them well and is billing them on the regular and knows very well what they had last month and what they had last week, and knows what their normal characteristics are. And it's especially when there is no local health care and you're driving, you know, 20 miles to get to health care, and this doctor's never seen you before. All they have to go on is he came in for a heart issue. She came in because her blood, you know, she's stressed. And when you remove how all that backstory that a physician that you have a relationship has, a primary care physician has, then all they have to go on is, why did you walk in today? And then I'll treat that condition. So that's the absence of healthcare within these communities.
Yes.
Plays very heavily into that end result.
And I would add to that, you know, I have a nurse practitioner that I've seen for 15 years who, absolutely knows me in and out, and I love it. But as soon as I walk into the emergency room, it is a total different story. The assumptions they make for the way that I appear. So I'm usually coming in an emergency room. It's usually in the middle of the night. I am a woman of color. I may have pajamas on. If I'm coming, it's serious. Have my hair wrapped up, and there is a whole lot of assumptions and those implicit biases that Miss Vivian mentioned that come along with my care. And it's funny to see the switch. And when I say switch, I mean inevitably someone in that ER. I've been a nurse faculty for 12 years. Inevitably, someone is going to recognize me as their former teacher, or someone's going to recognize me just from the community. And that switch of the care that I receive for before and after it's almost comical, the difference, the way that I am treated. And so, there's lots of ways how we can address that. Like Miss Vivian was talking about how U of L is doing. I know that myself as faculty at the College of Nursing, I do a lot of work with my students as they're coming in as they're leaving the program on cultural competency and how they deal with that implicit bias. And so I just want to put that out there because I know other people who've gone through that switch, and it's a shame that I don't receive the same cares when I walk in the door as I do after someone recognizes who I am.
Exactly.
I think that speaks to actually what every committee should be talking about on this commission, and that's talking about perception of the Black individuals or the Black and brown individuals that they see. Because I can guarantee you I'm going to walk out of my office after this call and I'm going to get certain looks and I'm going to get looked at certain ways. And it's because people have certain biases, and that comes from understanding each other. So until we change how those healthcare professionals understand African American people and brown people and people of other ethnicities, until we can change that cultural understanding of each other, because I know when I look at the panel right now, I know I see a bunch of ladies on here who I can talk to energetically, forcefully, and they're gonna know that I have no ill will about it. But that same energy and that same force that I come with somebody who hasn't seen somebody like me, they're going to be intimidated.
Yes.
And they're going to call me a thug and pull out a gun on me because I'm passionate about what's going on. And so I think that has to be involved in every one of these committees, is that implicit just understanding of who we have in front of us.
Yes. That was so very well stated.
Yeah, absolutely.
Something that comes to mind that played out during the pandemic, and this is something my friend Mike could probably expound on much more than I, is the access and availability of something that seems simple, like just fresh food, fresh fruit, vegetables, the AKA food deserts. When schools closed in the traditional sense and we had to come up with some non-traditional feeding routines using social distancing, we saw exactly how hard it was to make sure that communities had access to foods. And, again, God's Pantry played a big part in that, but I think it's not enough to have places that you may have to travel to. If you can't in your own neighborhood within walking distance, find some place that will have fresh foods and vegetables that won't cost you an arm and a leg, that aren't gouged. Right. It's like buying a meal to buy a small bag of vegetables and fruits. It shouldn't, especially when you have probably not enough resources based on some of the other things we talked about, like income and other disparities that all sort of play a role in this.
Really,
I
really
have
great.
a quick question
I just
before
wanted to-
we.
Okay, Brandy, and then we'll go back to you, Vivian, if that's okay.
When does the mayor want the end product? I mean, our recommendations.
That's a great question. And our goal was that we would have these meetings, and our goal is by the 1st of August. For her, the end game, I think, is around the middle of August. I can't remember the exact date, and I'll have, we'll put that, in a document and send that out to you all. But our goal was in these 4 meetings that we've established that we will set up some recommendations, and we also will be given a template for a report that we are to give to the mayor. And so we still need to receive that. I don't know if Dr. Williams has that or not, but we need to receive that. And Brandy, that's a great question, Dr. White. So we need to receive that so that it can kind of help guide our discussions and how we put things together and our thoughts and ideas. So we will get that sent out to you all prior to our meeting next week. It will give us a little more time to get our ducks in a row, but we really need to have a product by the last meeting that we had identified for this group.
That is a very, very tight deadline to come up with recommendations that these are generations and generations of problems. So I recommend that she take a look at this again, because this isn't something that you can solve just by putting together a committee. I mean, we can have recommendations, just some preliminary strategies, but this is a long-term thing. And I fear with a lot of things that we're seeing with University of Kentucky and the president sending out their messages, with the news even, that this is just gonna leave. Everything dies down and we're gonna forget about it. So I strongly urge everyone to look at this as a long-term solution and not something that's 60 days, because that to me shows me that it's not really that important. So this is a long-term strategy.
So I believe that the mayor is coming at it from the perspective of it being a long-term strategy. But what she presented to us was that because the passion of what we're feeling right now is right now, she wanted us to hit the ground running to come up with action for now.
Yeah.
Recognizing that it's going to take sustained effort to put our recommendations into play.
Lavora, I love you, but you know, we feel this all the time. It didn't just happen after George Floyd's death.
Oh, absolutely.
All the time.
Yes.
But I'll be quiet. I'm starting to get heated.
Oh, no, that's fine. No, we want to hear that passion.
I think it's worthy. Certainly something we can take forward. Now, do I believe it's going to change the process we're in? I think that's likely, highly unlikely. But I think that it's well stated, Dr. White. And I think it's important to say, just as Dr. Williams pointed out, I mean, it is a tight time frame, but she's wanting to take the momentum we have for the moment, show that there is some action being taken, but I think it's important for the long term that we find some things that are hopefully viable and will make a sustainable impact as we move forward, and may create things that will become long-term meetings or commissions or what have you. Maybe that wouldn't be a commission, but it could create some infrastructure for future existence. So it's the beginning, but not the beginning of the end. It's the beginning of hopefully some great things.
Dr. Talbert, can I add something?
And we'll make sure we get back to Vivian as well. Vivian,
yes, really quickly.
Yes.
Just as it is a short time frame, and as we when we get the template, I recommend actually at each meeting start filling in things as part of that template while this is going on, and I'll help to manage that. And actually open that up, make it a shared document that everybody can chime in on. It just makes it, I think, a lot smoother, and we won't forget the things that we talked about early on. So that'll be something that we can pull out any short-term things that may come about, and also build the case for those longer-term changes that need to happen.
Sounds good.
Thank you.
Mm-hmm.
Vivian's been trying to talk, so we're at the close. You also, Vivian, we want to hear from you.
Yeah. I just want to add one thing, just for us to think about for maybe future conversations is, I look at data all the time, and, we're not captured a lot in a lot of the healthcare data that comes out.
Yes.
And we have proposed, we've talked about it for years, to include some of those social determinant indicators, some of those social indicators in the electronic health record, capturing more of that person at every visit. And we also talk about, and I think COVID has revealed that, with the lack of racial and ethnic data, and how a lot of communities were being overlooked, and testing sites weren't being put in zip codes in areas that needed it, et cetera, et cetera. So I want us to think about that, because in a lot of the medical community, and not just medical, and all of these other focus groups, if the data is not there and we're not represented by the data, we're often not talked about. So, and I know Dr. White and Dr. Williams, you all know what I mean by that, as doing community-based participatory research. We have to have that information. And right now there are big gaps, there's holes in it.
Yes.
And in order for us to be at the table, we've got to show that this is why we need things and the recommendations that are being made, because the data supports this. So just to leave that thought with everyone.
And we love that. We love that about you and
thought.
the other colleagues who have delved into the research and the data, because we have talked about some reports, Dr. Williams and I, that we would like to have accessible for the group, but we're still gathering that. I think zip code information by race and ethnicity, because I think that helps target our focus, but we're still working on a source, and you may be able to help, Vivian, and many of you on the call. So I would encourage you between now and the next call that we talk about reports or data that you would like to have, that you think would help guide our decision-making. And we'll also send some things out to you as well, so that we're all prepared to come and chat again. And are there other unique things that you all believe we need to have on our next agenda, as far as making sure we touch base on? Now, obviously, the template's going to help guide our thinking and talking, but are there other things that you wish for us to provide for you or make sure we discuss?
Yeah, this is somewhat of a loaded subject that we could probably talk on for another hour, but you all mentioned, when you talked about cultural sensitivity, a lot of what it's geared towards is institutes of higher learning. So when students are being trained, they talk about diversity, right? They talk about multicultural sensitivity, inclusion, all of this stuff. However, at the licensing level, most of the time that stuff is kind of just thrown to the side. There is, in my field, there is no specific curriculum or training that psychologists must have to update or renew their licenses. So what I'd like to look at is, what are the requirements, what are the curriculums of licensees, and not only in psychology, but obviously psychiatry, social work, et cetera, because I really think that diversity piece needs to be included in license renewals. And again, that's something that we can talk about in more depth and more detail, and again, trying to see across disciplines what is included, because I'm not sure.
I think that's an excellent point. And I think that also comes with the regulatory agencies as well. What institutions are held accountable for to present from a race and ethnicity, but also cultural sensitivity and training. So they regulate everything else. You know, money follows those things. So it would be worth putting that on the table as well.
Absolutely.
TJC, CMS, and all those other entities. So it is 4:04. You all have been absolutely phenomenal.
Yes, indeed.
We will enjoy this very short time we have together, but Dr. White, I believe that we're going to have a product. Okay. I mean, I understand your anxiety about the tight time frame, but I think let's use it and we'll have to be active stewards of our time during the meetings, but between meetings as well, right? So Laboria, Dr. Williams and I will get together and we'll be sending you more communications, but Ms. James will be helping us get things out to you. And so our next meeting we will go with will be, can you repeat that, Andrea? I know you sent it in the chat.
Which is the 15th at 4 o'clock.
4 to 5, yes.
So, and Dr. Talbert, if we could speak briefly, the two of us, right after the meeting.
Absolutely, we'll do it. Okay, thanks to all of you. Have a fabulous evening. Thank you for your time.
Thanks, everybody.
Thank you.
Bye-bye.
Bye, everyone.
Bye-bye.
Bye-bye.